que vão nos ajudar certamente a entender um pouco melhor esses nossos velhos conhecidos, né, o FSH e o antimileriano. Então, seguindo adiante, eu gostaria de chamar o Dr. Glujovsky, que ele vai nos dar a honra de ministrar a aula de Non-Conventional Ovarian Stimulation Protocols in ART. Dr. Demián is a specialist in reproductive medicine and is a part of the medical staff at Cegyr, Buenos Aires, Argentina. Please, Demián, the floor is yours.
Thank you. Thanks a lot, Thais. Well, hello, everybody. It's nice to be here. Thanks, first, thanks to Huntington, to Aline, that was organizing everything. Well, let's talk a little bit, or for some few minutes, about just clinics, research in clinics. And we are going to talk about specifically non-conventional ovarian stimulation protocols in ART. I don't know why I chose this picture, but I guess that I was trying to show the several waves that we could have in an ovary over a cycle. So we will go to that in a minute. Whenever we talk about something that is not non-conventional, the first question is, why doing something that is non-conventional if we can do it conventionally? So eventually we have to see what is the evidence supporting it, and if that convinces us, eventually what is the benefit, if there is anything, any benefit. So I have nothing to disclose. I will not be boring with some theories, just to show you that there are several theories regarding antral ovarian follicle development in a menstrual cycle. So continuous recruitment, single recruitment episode theory, and follicular waves recruitment theory. And when we talk about follicular waves, there is some evidence showing that it is not only one wave, as we could have thought in the past, but there could be 2 and 3 waves in each cycle. And that's why we're starting seeing some non-conventional stimulation protocols that is not only starting a stimulation during the early follicular stage. So again, why doing novel strategies? And we could have some ideas regarding clinical relevance. So there are some patients needing an ovarian stimulation right now and not waiting for more. Patients doing an oncologic treatment, maybe it is important for them not to wait for the next menstruation and start the stimulation at that moment, but doing it now. So if we can do it, if we can obtain eggs eventually for fertility preservation, for example, that could be great, especially because we cannot wait for the following cycle. But it's not only the clinical relevance, but also the opportunity for those who have a low ovarian reserve. And in that specific clinical scenario, the question is, do we have something that is better for these patients? Because it is really tough to find good stimulation protocols that are better than what we have, which are not great, specifically for this subgroup of patients. But eventually, we have an alternative. And with this alternative, we have eventually also different clinical scenarios. For example, some patients that do not live in the city, that fly from some other countries, and they want to do a cycle, and maybe it's not just clinical relevance, it is the opportunity, not because of the low ovarian reserve, but because they want to retrieve more eggs in a single menstrual cycle. So we have there dual stimulation. We will talk about this in a minute also, but we can retrieve eventually more eggs in a single cycle, and not waiting 2 different cycles. And it is not because they need it, because the clinical scenario is like that. It is because it is convenient for them, if it is, and we will see in a minute, because they don't want to stay more time in a foreign country, or they don't want to do so long trip. So what are non-conventional COH protocols? Well, we can talk about random start. And random start, it is late follicular phase stimulation and also luteal phase stimulation. So random start is starting randomly, and usually, of course, out of the early follicular phase stimulation. So it could be late in the follicular phase or in the luteal phase stimulation, but we will also talk about double stimulation or dual stim or dual stimulation. So, and that is stimulating during the early phase and stimulating again during the luteal phase. And I will show you a couple of protocols that are published. But one of the things that were not easy to do the systematic review that we published, and we will show, I will show you the results in a few minutes. It is that they are not homogeneous. Not everybody does the same thing. So I will show you a few options, but you should know that as in conventional protocols, we have some variations. And mid to late follicular phase stimulation means starting 5 to 7 days after the menstruation occurred. Some authors suggest to do GnRH antagonists for 3 days, as you can see here. And then after that, when you have, whenever you have progesterone below 2, and usually the estradiol is low, then you can start what it is a regular or a conventional ovarian stimulation or protocol, but moved a few days later. So you can see here the FSH, eventually starting the GnRH antagonist at the end, and then doing the egg retrieval as you usually do. This is the luteal phase stimulation. And luteal phase stimulation, again, you can find different types of stimulation, but it is starting the stimulation 2 weeks after the patient had the menstruation. And that is usually, of course, with the progesterone that is high, that is over 3 to 7 nanograms per milliliter, with the corpus luteum that is visualized ultrasonographically. And again, some authors say, okay, let's start with GnRH antagonists, not all, but some propose that, for 3 days. And after that, with the estradiol that is low, again, start the ovarian stimulation. The same as you do usually with FSH, HMG, and again, GnRH antagonist at the very end with the triggering. And what about the double stimulation, the dual stim? Well, in this case, I will show you 2 or 3 options, very similar one to the other one, but this is one of them. So this is an early follicular stimulation at the very beginning. So whatever you do at the first part of the, usually in a conventional cycle, with or without the estradiol priming, but then the FSH or whatever you use, the GnRH antagonist, and doing the triggering with the GnRH agonist. And after the oocyte pickup, 4 days later, you start again with the second cycle in the luteal phase, again with the GnRH antagonist and the triggering and the oocyte pickup. And this is one of the options, but a second option could be something like that. So for follicular phase stimulation, and after doing the triggering, not only with GnRH agonists, but in this case, they suggest doing with regular HCG, recombinant or urinary, doing the oocyte pickup, and just after that, starting with the ovarian stimulation again, in this case, not using GnRH antagonists, but using medroxyprogesterone to avoid spontaneous ovulation. But again, a second cycle, just right after the egg retrieval, with the triggering and the oocyte retrieval. And a third option, just to show you that there are a lot of them, with clomiphene, letrozole, and the triggering, the oocyte retrieval, and starting with HMG, 1 day after the egg retrieval, and doing the oocyte retrieval some days later. In this case, again, they use medroxyprogesterone. So specifically talking about dual stimulation, Bayarelli, a few years ago, went for a SWOT analysis. I want to show you why some people want to do a dual stimulation. And they propose some strength, like a higher number of eggs obtained per ovarian cycle, and more patients obtaining more competent blastocysts. And no differences between eggs retrieved in the follicular phase and the luteal phase. Well, we will see that again in a minute. But the weakness, yes, more cancellations in luteal phase, and no randomized control trials or cost-effectiveness studies, which is obviously a problem. And freeze-all approach. So whenever you do a dual stimulation, you need a freeze-all approach. You cannot do a fresh embryo transfer. What about the opportunities? It might reduce time to obtain at least one competent embryo in a single menstrual cycle. As I told you, you do 2 retrievals in 1 cycle. It might be better tolerated, not sure. And theoretically, it reduces the dropout rate. I don't know. I guess that it is an opportunity because they do it in a single cycle. And threats, well, again, cost effectiveness, increased total dose gonadotropins, because we will see, but in the luteal phase, we might use some more gonadotropins. And also, there is no evidence of safety. And that is a problem. Whenever we do something that is non-conventional, we want to have some safety information. So if we don't have it, well, we should know that. So a couple of years ago, we published a systematic review with Romina Pese, Mariana Migens, Carlos Sueldo, Karina Lates, and Agustin Ciaponi. And we compared all the alternative ovarian stimulation protocols, so late follicular phase, luteal phase, random start, just as a group of random, and dual stim versus a conventional stimulation. And we wanted to see what we found in the literature. And I will stop in systematic reviews just for a minute, because I am asked very, very frequently, why do we need systematic reviews? And the strength of a systematic review is that someone or a team went for a search of all the evidence available. So whenever you do something in your own practice, that is what I do, is I go to look for some information whenever I don't know. And if I want to do a search for everything, it's probably that I will not get it, just because I don't know how to do it. I mean, to get everything, because I don't have enough time, because I don't have, because I am just myself. And in a systematic review, there are pairs of reviewers that eventually they agree, but they could not, and discuss, and they classify the quality of the evidence. And in the end, when I am the reader of a systematic review, I can say, okay, I have all this information gathered together with the quality of the evidence that is analyzed. So, so what if the systematic review says that the quality of the evidence is not good, or that we don't know something? That happens a lot, right? Well, if that happens, that is a problem for all of us. But it's not that, okay, it's not a good piece of information. It is that we don't know something about a specific topic, or that we need more research about that. But we, as health carers, should know that eventually don't have enough information, and eventually share this information with our patients if we think that that is important. So this is what we did. We went for the randomized control trials. Whenever we do a systematic review, we like to go just for randomized control trials. But in some cases, we don't have enough. So whenever we don't have enough, again, that is a problem, but we want to have the best available evidence, because it is always better to have the best available evidence than not having any evidence, or, I mean, not having any information. So we went also for before-after studies, retrospective cohorts, and prospective cohorts. But as we didn't want to have just bad information, we did a sensitivity analysis. Sensitivity analysis means that we decided to meta-analyze, to pull data only if they were randomized controlled trials or if they were non-randomized studies with overall low and medium risk of bias. So we wanted just the good information that we could retrieve. We did not include studies with serious or critical limitations because we don't want to have just anything. We want to have the best information available about this specific topic. And yes, it was a hard work, more than 1,000 studies that we read, and we finally end up in 15 studies that we included with 22 comparisons. And in those 22 comparisons, we found 4 different interventions. So 11 that compared luteal phase stimulation versus conventional stimulation, 5 late follicular phase stimulation versus conventional, 4 dual stim versus conventional, and 2 random start stimulation, which is a mix of this, versus conventional stimulation. And they were done in different populations. Again, that is a problem to pool, so we have to be very careful not to put pears with apples. 11 infertility treatments, 8 in poor responders, 3 in general infertile population, 2 in egg donors, and 8 in oocyte preservation due to cancer. And this is what we found. This is a forest plot comparing luteal phase stimulation versus conventional stimulation, and we found out that there were no clinical relevant differences in M2 oocytes. So we can rule out a difference in all these groups. And we found, we analyzed separately poor ovarian reserve, general population, and egg freezing for cancer. As you can see, there are not too many studies. This is all these are all the studies that were published at that moment for this. And we decided to include, as you can see, the not estimable. They are studies that were classified as high risk of bias, and that is why we did not include it, as I told you, in the sensitivity analysis. So we finally put the information of the good studies, and we found that, look, minus 0.5x with a confidence interval between 1.6 minus 2.6, so nothing. There is no differences in terms of M2 obtained in poor ovarian reserve. The same thing here, 0.5 in general population. And for egg freezing, we have a larger confidence interval, so we are not so, we have less clear information at that point. So the first thing could be that for luteal phase stimulation, we don't have, at least in these populations, differences in M2 oocytes. The other thing that we analyze is that is the length of the control ovarian happy stimulation protocol. So the luteal phase stimulation probably increases the time, and these are days. And you can see here that in general population and in egg freezing, so in these two, we see that the number of days that we needed to do the egg retrieval were 1.9 days more in the luteal phase in comparison with the early follicular stimulation. So it looks like it is the dose of the gonadotropins that was mentioned in the SWOT analysis was coming from here. And yes, it is a longer cycle in the luteal phase, at least for general population and the egg freezing. For poor ovarian reserve, this is something that we cannot say because the confidence interval is, again, a little wide. So the central estimation is not different, but the confidence interval is too wide to say something. So the first summary that we can do about luteal phase stimulation versus conventional stimulation is that, and I'm talking about low certainty of the evidence, so for outcomes that had low certainty of the evidence, again, we could have moderate, we could have high, and we could have very low. So I would love to have high and moderate. We didn't, because some reasons related with again, with the quality of the evidence. But we have low certainty of evidence that the total retrieved eggs and the metaphase to oocytes were not different between luteal phase and conventional stimulation, and that the days of stimulation were probably, or I should say may, because of the low certainty of evidence, they may be higher in the luteal phase stimulation. And finally, the cycle cancellation. I didn't show you the first plot, but the cycle cancellation showed a really large odds ratio, 1.9, to have more cancellation. You can tell me, okay, the confidence interval goes through the one, so you cannot say that that happens. That's true. But so currently, we know that we should pay attention not only to the no effect point, which is the one for odds ratio, but also for the confidence interval and for the central estimation. So when the central estimation is really high and 1.9 is high because it's almost double, we should know that it could happen. And just pay attention. We need more research, but there could be something there. What about clinical pregnancy, miscarriage, live birth? Well, very low evidence, so we cannot say anything. So whenever you think about doing something like this, you should know there is no evidence, at least by today, to say it is safe or it is not, it is effective or it is not in terms of clinical pregnancy, live birth rate, and miscarriage rate, comparing luteal phase stimulation versus conventional. What about dual stimulation versus conventional stimulation? Okay, in this case, we can say that dual stim probably increases the M2 in comparison to a single conventional stimulation. Well, it looks like it is obvious. If we stimulate twice in a cycle versus only once, so the first part is the same thing. So if we add something in the end, we will have more. So it is what we expected. Unfortunately, we don't find any studies comparing dual stim versus two conventional cycles. And that is what we want to compare. So if there is any researcher that want to do that, that is a good idea, to compare one dual stim cycle versus two eventually consecutive single or conventional protocols. But if a patient needs to do everything in one cycle, because she's going to do an oncological treatment, because she is flying from some other country, or because whatever, but she cannot extend the time of stimulation. Okay, doing it, we could know that that we would have more eggs. How many more? 3.3 in average, more than doing it just in the early ovarian. In the early phase, in the early follicular phase. So what about the results? Here we have some moderate certainty of evidence, which is good. So we know that we have more eggs in dual stim, that we have more M2 in dual stim, and we have a low certainty of evidence that we may have an increased live birth rate. Do we know that? No, we cannot say for certain. And the evidence, I mean, the certainty of the evidence is low, and it goes through the one. But look at this. It is really close to the non-effect point. So that is potentially good. Potentially. We need more research. What about the rest? Again, very low, very low, very low for clinical miscarriage, cycle cancellation. So should we be confident about this? Not very, just low certainty of evidence. So this is something it is not probably good enough evidence. So strengths and limitations. This is the most updated systematic review published by the end of 2020. The search was in most important databases with not language restrictions, which is a strength. And we performed an analysis by subgroups of patients to avoid any methodological flaw, which is also important. So we based our conclusions on evidence with low, moderate risk of bias, which is probably a limitation. Most certainty of the evidence is low to very low, as I told you, and we could not retrieve definitive conclusions based on this evidence. So is it important to have a piece of research like this? It is, because otherwise we cannot say anything about doing an alternative protocol or not doing it. And eventually we should know what we certainly know, more or less, and we really don't know, not based on a single study, based on pooling all the data that we have. So in summary, no differences in number of retrieved eggs when comparing luteal and early follicular phase stimulation. Early follicular phase stimulation is probably a day or two shorter than luteal. No high-quality evidence was found for live birth rate, clinical pregnancy rate, miscarriage rate for luteal phase stimulation. No conclusions for late follicular stimulation and random start stimulation could be retrieved, as the evidence was of very low quality, and that is why I didn't show any result. And finally, duostim may be associated with a higher number of M2 oocytes. Euploid embryos, again, I didn't show it. It came from a single study, and almost doubling number of obtained in early phase follicular phase stimulation. Finally, scarce low certainty evidence suggests that random stimulation and luteal phase stimulation could be valid options if needed. Duostim could be a possibility in low ovarian reserve if needed. We need much more evidence in all those different subgroups to fill this gap of our knowledge. So thanks a lot.